Good morning and welcome. I'm just waiting for participants to log in. I see 39 in so far, 44, 45, 48. Give them a few. Okay, looks like smaller attendance than we typically have, but I guess that's not unexpected. About 60 people have joined. So why don't we get started? So we've got a complex agenda today. We're going to start with a short COVID update. Dr. Lesho will do a little epidemiology update, and then either Dr. Sandhi or Shepard will be talking about the recent data on Decadron use in COVID patients. And then we're going to move on to our R3 talk and a virtual white coat ceremony at the end. So please stay on for that. I know Michelle is texting me that the number underrepresents the number of people because there are some people seeing this live in the Twig Auditorium. So welcome to all of those people. Those are, I assume, the new R1s are sitting in the auditorium watching this. And on this count, they only count as one person, but welcome to all of you. And you know, this Grand Round session is dedicated to you. So the ground rules for this are only the panelists who you can see are able to project their audio and video. The audience is able to participate by asking questions. Please don't use the chat line. If you have a question for one of the presenters, use the Q&A function at the bottom of your screen. And I will be able to see those questions and will direct those to the right person if we have time. We have a lot of stuff to go through, and so we'll see if we have time for questions, but we'll try to pause after the first COVID part to see if people have questions. So with that, why don't we get started? Dr. Lesho.
Okay, can everybody hear me okay? Hi, everybody, and congratulations to all the R3s graduating and the new R1s coming in and everybody. I'm gonna have lots to talk about, and I'm gonna keep it brief in under 5 minutes. First, never miss an opportunity to mention the importance of CAUTI and CLABSI prevention. You know, we say our rates are, headed a little bit in the wrong direction, so please be mindful. Any questions, just please reach out to infection prevention, culture judiciously and thoughtfully. Number two, had a little reminder last week about the importance of gowning. So we understand the shortages make it challenging to keep up, all the different styles of gowns, some tie in the back, some tie in the front. There'll be inspectors periodically coming through, and they're pretty hard graders. So there were some observations that, I thought they were rather hard, and they said, well, not tying it the right way in the back. So just two little reminders. Now I'll get into the more maybe interesting stuff. So what's happening with COVID? New York State, it's looking good. Monroe County, looking good. Positivity rates are low at record lows. Admissions and occupancy for COVID is lowest since pretty much a long time. Locally, we're heading in the right direction. We think we made it pretty much unscathed through the Memorial Day weekend. Still a little bit early to see if the protests had any impact or a spike. The bad news, especially if you're a customer of the Dragonfly Pub in downtown Rochester, is that alert has been issued from the Department of Health that if you were there on June 8th, you have been exposed. It was crowded, people weren't wearing masks, and there have been cases now linked to the Dragonfly Lounge. If you've been there, contact the health department. We see other states that are heading in the really wrong direction. Alabama, Florida, there's 8 or 9 states now that are reporting record numbers of either positive cases, percent positives, and hospitalizations. So it's just a reminder of that. And there was one question from one of the audience members that says, well, what happens in the summer? Where does the virus go? I mean, I don't know. I defer to the virologists on that one. I don't know if anybody really knows. But there was a preprint paper that others were reviewing for JID, Dr. Walsh and all, and it was a review of that. And there was a contention that in colder, drier weather, one of the things that may enhance the spread is that the viral membrane is much more stable. And so that could be one of the things. You might see in the news about mutations, certain mutations, increasing the number of spikes, so we have that going on. So finally, I want to end with an interesting report on our local data, which we have compliments of our database people, began by a project, Dr. Hannah. Dr. Chen was launched. We got the assistance of System Incident Command. We are grateful to those data abstractors. And then finally, we're grateful to Dr. Jonathan Bress and Donna Newhart for putting it all together in the form of statistics. So I'm going to try to share my screen, and we have the first set of descriptive statistics for 399 patients treated at RGH. So let me attempt to share my screen. And can you guys see that?
Yes.
All right. So we have here total of 399, outpatient, inpatient, p-value. And we have some, all this says is that these differences were statistically different between these two groups. Again, I remind, it's not causation, it's just a statistical observation. So between inpatient and outpatient, you see some differences there for age, occupation, not much for smoking. Then we go down to the comorbidities. Not too surprising, but hypertension, diabetes, cardiovascular disease. Somewhat known, but our data is very consistent with that. Morbid obesity. Let's go down to medications, maybe perhaps a little more interesting. You have ACE and ARBs fell out as statistically significant, along with statins and acid suppression. And Dr. Bress reminds me that, multiple testing criteria. So the more variables you test, the more tests you conduct, the more likely you are to find a statistical significance, and you correct for that with multiple test corrections or Bonferroni and stuff like that.
You need to scroll down, Alessio, you need to scroll down so they can see the rest of your screen. Is there anything lower down there with medications and so on?
How's that?
No, we don't see it.
No, don't see the lower part of your, just see the upper part of the document. Just scroll your screen. No, that's okay. Maybe just speak to it. It's cut off at medications.
Oh, medications. Hold on. Page 2.
Maybe just scroll it to bring the medication at top of the page.
Huh. Oh, well. Nope, now it's gone. Anyway, I'll be happy to send that to, I'll be happy to send that to Lisa Phillipson and Dr. Patak, and we'll share a PDF of all the data for that.
We'll just
but more exciting is the fact that tomorrow in Washington, D.C., at the National Academy of Sciences, Engineering, and Medicine, formerly the IOM, the Institute of Medicine, they are hosting a public meeting on data needs to monitor the evolution of SARS-CoV, and we've been invited to do a brief presentation. And we are going to make a case that this is the kind of grassroots approaches that can be done just about anywhere with interested staff and residents that will contribute to that project, the National Action Plan, whereas you get several networks submitting clinical data. And the ultimate goal is to try to link that to the whole genome sequence of the virus, but more to follow on that. So thanks everybody for your support. I'll have more to follow in the upcoming weeks. The way forward with this data is to do some other approaches, more survival analysis. And Dr. Bress talks about a method called gradient boosting. And that will give us some more insight and a little bit more interesting report. So with that, I'll turn it over.
So I'm going to ask one quick question. Dr. Sham asks, he says the absolute number of patients in the ICU is less than half compared to the peak 4 to 6 weeks ago, despite people still being diagnosed. Is the virulence of the virus changing?
I have no idea.
No idea. All right.
I think it is, some of it probably is because of a much higher number of testing.
Yeah.
You know,
that is part of the
hospital admitted patients percentage coming to ICU. I'm not looking and analyzing the data right now, but generally seems to be very, very similar. The nursing home patients came to a hospital, a week or two, ICUs got filled, and now the ICU number is going back down.
Yeah.
So I'm struggling to stop sharing my screen, or don't I have to?
You do have to stop sharing your screen, but in the meantime, Dr. San.
I got it. Here we go.
Yeah.
Am I done?
You're done.
Great. Sorry.
Dr. Sandhi is going to tell us about the new Decadron data that's been all over the news.
So could you guys see my screen with the recovery trial?
Yes.
Okay, so yeah, this thing came up. Actually, Todd was supposed to present, and he's busy rounding in ICU and probably has a sick patient outside. So I'm going to try to do this. When the surge happened in New York City, and even before that, there was the first recommendation by World Health Organization and all the societies was steroids should not be used. In ARDS, steroids have not shown a benefit. But very quickly this changed, and Critical Care Society puts low-level recommendation to start using steroids. And we have been using steroids as this started in New York City from very early on. We were using much higher dose than this trial is showing. We were using salomedrol at almost double the dose for a very similar duration, and I think we saw a benefit. So anyway, this came out in CNN. That's how we saw it. It was a pretty big study. Inclusion criteria was pretty much every COVID patient suspected or confirmed at University of Oxford. All hospitalized patients, they used it. They did not, reserve it for ventilated or oxygenation only. Anybody who got hospitalized. At RGH, I don't think we hospitalized anybody who does not need oxygen. Primary outcome was mortality at 28 days, and the dose they used was dexamethasone 6 milligram IV or PO for a total of 10 days. They did not. There is no mention of tapering the dose, and it's like, it compares to about 30 milligram of salomedrol for PO for 10 days. So it probably is okay not to taper. And the dose we were using at RGH was pretty much double than this dose. And we were doing it for 5 days, and then we were tapering it over another 5 to 6 days. Total about 2,000 patients, 2,100 patients received dexamethasone in this study. 4,000 or so had usual care. Overall mortality reduction was 17%. It was highest in ventilated patients, which it was reduced by third, and in patients on oxygen, not on ventilation, was reduced by fifth. And there was no mortality difference seen in people not on oxygen. So Todd just walked in, and we as a group discussed it. We discussed with infectious disease also, and we are recommending anybody on oxygen get start on this trial. The patients not in ICU could be on PO, and the patients on ventilator will have to be on IV. Todd, I just presented the slides you made. Anything you want to say about?
Yeah, I mean, the results aren't published, so you can just go by what's in the news releases and on the trial website and on the NIH website. So
yeah, so that's the question being asked on the group too, is are we concerned about jumping on this before seeing the published study, because all we have is what's in the press?
Yeah, I think it's like anything else. What's the bigger risk here? You have a pretty reputable university, obviously, and a country that's done a really good job of getting people recruited in a huge population of patients. Is it a bigger risk to start people on a little dose of dexamethasone and wait, right now, or wait until the published results are peer reviewed and then start? I think the bigger risk is to wait, because the downside's pretty low from 6 milligrams of dexamethasone a day. And for our ICU patients, it's actually a dose reduction, because most of us have been giving higher doses of steroids.
And this was a very similar experience from New York City. And our dose recommendation in ICU and even on the floors, anybody above 6 liters of oxygen was double the dose of steroids than this one. So we are using it. And if you analyze our limited data, RGH mortality is 33% for COVID patients all over, including all patients. And ICU mortality within ICU is about 22, 24%. I think the difference is some of the comfort care patients go out on the floors and then they pass or they die over there. And that mortality is overall 10 to 15% lower than international data which has been coming out. And I probably think that the steroids are contributing to that reduction in mortality. And we have seen clinically people do better after steroids. We have not seen increased risk of infection. And I think a 50%, almost 50%, as Todd said, we will be doing about 50% dose reduction in steroids. So I think it's safe and we should start.
Sounds reasonable.
The only thing we're extending will be now people who are on 2 liter oxygen. We were already doing it on 6 liter oxygen.
All right, sounds good. So we're going to move on to the second part of this grand round. So I see that there are 121 participants now, and this is not counting the people in the Twig Auditorium, because all the interns are there, and I think some of the residents are there as well. So I'm going to do a quick poll, understanding that we will underestimate the number of residents because they are not able to individually poll in the Twig. Can we stop sharing, Dr. Sandhi? Oh, he walked away. Okay. Well, that's the nice thing about being administrator on this, is you can stop them from sharing. So here's the poll. Which of these describes you the best? Can the audience please answer?
I'll see. I don't know what you're saying.
Okay. So I'm seeing primary care physician about 20-25%, specialty physician 25%, APPs 15%, residents 12%, but again, that's underestimate because we're not counting the ones in the Twig, and nurses 6%, student 5%. All right, thank you very much. Dr. Silver, do you want to introduce the R3 talk?
Yeah, well, welcome everybody. And today is the day when our new interns arrive at RGH. And as by tradition, we ask one of our outgoing graduates to talk to them and talk to everybody at Grand Rounds about their research and achievements as to use as inspiration to interns and to all of us. And today I'm very happy to introduce Dr. Raseen Tariq, who you may know, who is a graduate and is going on to be a chief resident with us. We're so happy about that. And she's going to talk about her journey in residency and will present some of her research findings today. So Raseen, please go ahead. Welcome.
Thank you so much, Dr. Silver. I'm going to start sharing my screen. Can everyone see my screen? All right. So today I'm going to talk about my research journey as a resident and even before that. So a little bit about myself. I'm originally from Pakistan, and I graduated in 2015. And from there, I was fortunate to get a postdoc research position at Mayo Clinic, and I started in 2015. And there I worked there for 2 years in the Department of Gastroenterology. And as we start a new thing, it needs baby steps, and so was this. This was actually my first publication, which was actually a case report about acute pancreatitis. It was published in 2015, and from there I continued working, and this was my first poster, which I presented in one of the well-renowned gastroenterology meetings. And as a naive person who goes to a first meeting, it was a very good experience seeing the people who you actually read in the papers. You were actually able to meet them and discuss their research and projects. And fast forwarding a little bit, this is one of the papers that I am proud of sharing. It was a meta-analysis about the association of PPIs and H2 blockers with recurrent C. diff infection. And it was very well received in the medical community. It was covered by quite a bit of media outlets as well. But I think the one thing that I would like to mention is because of this study, it provided an evidence that PPIs are associated with recurrent C. diff, and it did change some medical practice. It was actually mentioned in UpToDate as well that if the patients are taking PPIs and they have C. diff, then because of the increased risk, we should consider stopping them if appropriate. And because of all this research and with the support of my mentors and colleagues, I was awarded Outstanding Research Fellow among fellows of about 400 over there. And then I start here. So this is 3 years ago, especially for interns. This is where I was 3 years ago, where you guys are today. And I know you guys must be anxious, nervous, but believe me, if I can do it, you guys can do as well. This was the picture of our white coat ceremony. And then continuing throughout this 3 years period, I was able to continue my research, and I went to quite a bit of meetings, and even at RGH we had quite a bit of research exposure, and these are few of the glimpses of that. And then few of the papers that I was able to publish during my residency, most of them are actually meta-analysis, and most of them are actually on, I guess, GI stuff. And I should stress this point that I think our program is very helpful. If you guys take any initiative, the program will help in any way as possible to help you make that happen. And today I'm going to talk about one of the trial study in detail, which I did. It was a meta-analysis. Most of my research have been on fecal microbiota transplantation and its outcomes in C. diff infection and other diseases in GI systems. So this was actually published in 2017 in one of a major infectious disease journal. In which we actually looked at the cure rates in controlled trials of fecal microbiota transplantation for C. diff. This paper has actually been cited in UpToDate as well to evaluate the efficacy of FMT in clinical trials. So now going in a little bit background, as we all know that C. diff is the most common cause of hospital-acquired diarrhea, and the risk of recurrence after first C. diff episode is about 20%, and it does increase to about 60% with use of additional systemic antibiotics and subsequent C. diff recurrences. I know this might not be, you guys had your breakfast, but I'm going to talk about the FMT, but bear with me for that. So basically what FMT is, it's installation of stool from a healthy donor into a recipient. What it does is it is an attempt to reestablish the normal diversity of gut microbiome, which is mostly disrupted in these C. diff patients, which is actually called the dysbiosis. And once the FMT does establish the microbiome, we can avoid the prolonged courses of antibiotics after that. A little bit of history of fecal microbiota transplantation. So this is not something new actually. It was in the 4th century that human fecal suspension by mouth was used to treat food poisoning or severe diarrhea. And then in 16th century, Lis Chesuan was another person who used a variety of fecal suspensions to treat diarrhea, abdominal pain, vomiting, and all those symptoms. And then in 17th century, in veterinary medicine, horses and cows have been given stool suspensions to treat their GI symptoms. And then first time in human persons, the actual FMT was described in 1958. And since 1990s until 2015, there are more than 1,000 cases of FMT being reported for the treatment of C. diff. This is one of my many favorite slides in which it describes how the FMT works. So the first slide, it describes the normal homeostasis in the gut environment, where we have the commensals and the bacteria. And when someone is given antibiotics, it results in dysbiosis. This dysbiosis is usually transient, but if someone gets exposed to C. diff, this transient dysbiosis becomes persistent dysbiosis. And once someone develops persistent dysbiosis, the person keeps on getting these infections because of those. And what FMT does is it disrupts the dysbiosis, clears the C. diff clearance, and then again develops those homeostatic environment. What about efficacy of FMT? Is it efficacious? It is useful or not? So in observational studies, the efficacy of FMT for the treatment of recurrent C. diff is about 85%. But it has been variable in trials, and I'll talk a little bit about 2 trials that do describe it. This was one of the meta-analysis actually of observational studies, and it included 11 studies, and overall resolution was about 90%. But when we talk about trials, this was one of the placebo-controlled trial, which was published in 2015. And they actually randomized the patient to receive FMT with the donor stool, which was the healthy stool, compared to placebo, which was actually their own stool via colonoscopy. And their primary endpoint was resolution of diarrhea within 8 weeks. So the overall result did show that the FMT group had resolution of diarrhea in about 91% of the patient, and the placebo group only 63% of the patient had resolution of the diarrhea, and the p-value was statistically significant as well. So this trial did conclude that FMT administered via colonoscopy was significantly effective for prevention of recurrent C. diff. But then this was another study published in 2016, and it did include quite a bit of patients, about 300. They gave FMT via enema with fresh or frozen stool, and their primary outcome was also if there is resolution of diarrhea without relapse. And the results were not as promising as described by the other trial. The efficacy of enema was only around 60 to 62% in all the groups after 1 enema. I would tell that even like the efficacy did increase after 3 to 4 enemas, but up to 80 to 85%. But if you're considering just one enema, it was kind of equal to what other drugs have been used to do. So given these discrepancies, like one trial describing 90% efficacy and the other trial describing 60% efficacy, we performed a systematic review and meta-analysis to evaluate the efficacy of FMT in randomized controlled trials. And we also compared those with the open label trials. So as a regular meta-analysis, we did use the PRISMA guidelines to conduct the meta-analysis. And the selection criteria, as I described, was only clinical trials. Either could be open label, randomized trials with control group, without control group, or placebo controlled. Study population was patients with recurrent or refractory C. diff who were treated with FMT via any delivery modality. And we did exclude the observational studies and also the studies that did not evaluate the clinical resolution of C. diff as an outcome. Just to tell the thorough search that we did from 1978 through March 2017, and we did search quite a bit of databases to make sure that we don't miss any studies. So risk of bias in all the trials that we included, we assessed it using the Cochrane collaboration risk of bias tool. And this tool really helps to assess the clinical trials to see if they were randomized, what was the completeness of the outcome, and if there was any evidence of selective outcome reporting. So our outcomes, our primary outcome, as I discussed, was to focus on assessing the clinical resolution rate for recurrent C. diff after initial FMT in a controlled setting. And we did not include the patients treated with multiple FMT after clinical failure with initial FMT. And then in the secondary analysis, we did include the overall cure rates. Let's say if the patients who had failed first FMT and they were treated with multiple FMTs to see if it helps. So this was the flow sheet that did how many studies included. So if you can see on the bottom, there were 13 studies that were included in this systematic review and meta-analysis. Of those, 10 were full text studies, 2 were conference abstracts, and 1 was actually press briefing of a trial which was not published yet. I'll not go in the detail of the include study, but just to give an idea, this includes like the study year, the design of the study, how many patients they had. We made sure that the indication of FMT could be the recurrent C. diff or refractory C. diff. We also made sure that we know how the C. diff was tested, how the stool were delivered to them, either through a colonoscopy or through mouth, through an NG tube, through an endoscopy. Stool type, it could be either fresh or frozen stool. Donor type, it could be anonymous donor or a family donor, and then the follow-up period. So most of the studies were from US, a few were from Canada. Most of the studies used colonoscopy as the route, but few of them used the NG or the endoscopy as well, and few of them used enema. And the stool type was mostly frozen, but some used fresh as well. And this was the results. So overall clinical cure with single FMT. So this was the overall cure. We had like 13 studies, about 600 patients, and the cure rate was about 76% in a controlled setting with single FMT. It seems to be a little bit lower compared to what has been reported in the observational studies. And so we wanted to then see that if it improved with multiple FMTs for the patients who had failed one FMT, and it did improve, and the efficacy increased to about 89 to 90% with multiple FMTs. And then to see if there is any difference between the trials with a control arm, placebo control trial versus open label, we separated those and then reanalyzed the data. And there was actually quite a significant difference. So the first, the A forest plot, it actually tells the cure rate in controlled trials with control arm, and it was actually only 67%. But in the observational studies, the efficacy was about 82%. So most of the low efficacy trials were actually randomized control trials. So this was the subgroup analysis we did to see if there is any difference based on like delivery modality. And we did found that colonoscopy was more effective compared to enema. So if the FMT is administered via colonoscopy, the efficacy was about 87%, while the enema was around 66%. However, the efficacy of oral route was equal to the colonoscopy with about 81%. Then to see this question does come to the mind if there is any difference between type of stool, as if the fresh stool is more efficacious compared to frozen, and we did not find any difference. However, based on the C. diff type, the FMT was more effective for recurrent C. diff compared to refractory C. diff, which most likely is in line with the results of prior trials. And then based on the donor type, if it was an anonymous donor, known donor, there was no difference. And again, based on the type of C. diff testing, the EIA or the both PCR or EIA, there was no difference. What about the adverse events? Most of people do have these questions. Among all these trials, there was no serious adverse events related to FMT. Most common reported adverse events included like nausea, diarrhea, flatulence, self-resolving abdominal pain, bloating, and constipation. And none of the patients needed hospitalization for any of these side effects. So just summarizing, we found that there was a difference between the efficacy of FMT in randomized controlled trials and observational studies. And we postulated that it could be because of the application of strict inclusion and exclusion criteria in the controlled setting. And this leads to inclusion of a very small proportion of patients in the trials, and it could have limited the generalizability of these results to patients seen in the clinical practice. And again, the study population in the randomized controlled trial might not be the true reflection of the patient that we see in the real world and that were reported in the observational studies. So in conclusion, in our meta-analysis, we did find a couple of things. First was FMT via colonoscopy was more effective than antibiotics for treatment of recurrent C. diff. And we could use fresh stool or frozen stool. It was equally efficacious. FMT using frozen inoculum could be effective in the same way. And single FMT in an in the randomized controlled trial was maybe associated with a lower cure rate. And then further studies should focus more on having clear definitions of recurrence and responses and use of less strict inclusion criteria in the randomized controlled trial. And again, this FMT, although it's like been reported since 2013 and has been in use since then, at least in US, but we still do need large follow-up registries to determine the true efficacy and safety profile of FMT for recurrent C. diff. So I graduated last week, and this is my chief residence, and you guys will meet all of them today. And best of luck. And if you guys have any questions, I'll take that.
Thank you. That was wonderful. Your presentation must have been crystal clear because I don't see a single question on the Q&A panel. So you must have answered all their questions. Fantastic. Thank you. So before we move to Dr. Silver, just a couple of housekeeping announcements. This would have been the last scheduled grand rounds for the year, and we usually take a break for the summer. But at popular request, we are going to have updates over the summer. So the next intended grand rounds will be on July 8th. So July 8th and July 30th. And then we'll do it twice in August as well. And also I wanted to let people know that this evening at 6 o'clock, we are doing a farewell for Dr. Bernstein. This was something we had hoped to do in person before he left. It got derailed by COVID. And so we thought at the very least we ought to do this Zoom event. There's an interesting movie into which a lot of work was put that will be shown as part of this event. So those of you who knew Dr. Bernstein are welcome to attend. You'll get a Zoom link just like Grand Rounds, and it'll be from 6 to 7 p.m. today. So with that, I'm going to ask Dr. Silver to start the white coat ceremony with the introduction that normally we would be in the Twig Auditorium with faculty handing out white coats to these interns. But this year, this is the way it needs to be. So Dr. Silver.
Right. Well, thank you, Dr. Patek. As Dr. Patek was saying, this year is quite different because we can't all gather in the auditorium and because all our interns have not arrived. We do have 12 that are in the auditorium now, actually. But hopefully all the interns are here on Zoom from all over the world. And they're definitely here with us in spirit. And I want to assure them that they will make it here and make it here soon. We're very proud to have them. And what I'm going to do today is just to mention their names and show their faces and just to kind of introduce them. And actually this class, there are 12 in the auditorium now, and there's 12 more, so 24 in a larger class for us for the 2023 class. And at the end, we're going to think of them as being donned with their white coats. And then I'd like everybody that's listening to say the RGH pledge to yourself or out loud and kind of remember when it was your first day as an intern. The first intern is Syed Abbas. Zaraz Anjum. Jay Papai. Arun Bala. Swati Chand. Mahmood Isa. Ahmed Akaperi. Hafsa Faisal. Rapsimira Gill. Ido Goldenberg. Lakshmi Nair. Charu Iyer. Gustav Joshi. Hanya Liaquat. Hongli Liu. Soon Lo. Chengu Liu. Carlos Castillo. Saif Urehman. Hassan Saeed. Tamer Al-Tamimi. Monica Sharma. Salman Saeed. and Kaiwan Zhu. So along with me, let's even if you're alone by yourself, just to recite the RGH Internal Medicine Residency Program Pledge. I pledge to uphold my obligation to patient and colleague, as healer, to be professional in attitude and demeanor, as scholar to be thoughtful and collegial, and in recognition of our tradition and academic lineage, to be partner and architect. So with that, welcome the new interns here and around the world to RGH, and welcome to everybody. And thank you very much.
Thanks again. See you on July 8th.